Good evening, everybody. It's great that you're back again. This is for the 6th time that we are presenting ESGE Papers of the Month, Evidence-Based Medicine in the Endoscopy seat. This session will be shared by myself and Helmut Messmann, and as you can see, we have 4 exciting panelists. First, Yutaka Saito from Japan, Mathieu Pioche from France, Torsten Beiner from Germany, and Marco Pennacchio from Italy. So really an international group of excellent endoscopists. This is actually the 5th year that ESGE is offering you this opportunity to attend these webinars, high quality presentations on endoscopic topics. And I think the most exciting part is that you can interact with speakers and you can participate in the discussion by submitting online questions. And if you like to do this, please use the Q&A box. I like to ask Helmut to introduce the first 2 speakers for this session.
Hello, good evening. Also from my side, warm welcome. Today from Hamburg, from the DGWS Congress of our society. So maybe there are some background noise. I hope you can understand me and the transmission is fine. It's really a great honor and pleasure for me to introduce now 2 excellent experts in ESD. Yutaka Saito from Tokyo will give his presentation on his paper, which was recently published in Gastroenterology. And we have also an outstanding expert from Europe, Mathieu Pioche, who has a lot of experience in ESD. And now I welcome the 2 speakers, and I think we can start with the presentation of Professor Saito.
This is Yutaka Saito from National Cancer Center, Tokyo, Japan. The long-term outcome after ESD for colorectal epithelial neoplasia, a Japanese prospective multicenter cohort trial from CREATE-J. Some slides here were presented during DDW 2022. The results of this study have been published in Gastroenterology. Long-term outcome after ESD for colorectal epithelial neoplasia, a Japanese prospective multicenter cohort trial, CREATE-J. It has been reported that piecemeal EMR lowered the incidence of local recurrence by ablating the mucosal defect margin. Recurrence after piecemeal EMR is, however, difficult to treat with EMR and often requires surgery, even for benign adenomas. In addition, in the case of piecemeal EMR, it's difficult to accurately diagnose SM invasion, and there is risk of missing an appropriate subsequent treatment. ESD is the solution to solve these problems. Although good short-term outcomes have been reported from the West as well as Asia, and single-center long-term outcomes, there have been no long-term multi-center outcomes. We therefore conducted a multi-center large-scale prospective cohort, investigating the long-term outcomes of colorectal ESD, and presented the short-term results at DDW 2016 and local recurrences in the 4th year at DDW 2021. The primary outcomes, the 5-year survival and intestinal preservation rate. The secondary outcomes is the rate of local recurrence and the metachronous invasive cancer occurrence. 20 high-volume centers all over Japan participated in this CREATE-J. The study protocol is as shown. All patients who were scheduled for colorectal ESD were enrolled, and ESD was performed on nearly 2,000 patients. Curative resection followed JSCCR guidelines. Surveillance colonoscopy and survival survey scheduled at 1 year, 3 years, and 5 years after CESD. JGS guidelines published in Digest Endoscopy, the official journal of JGS and WEO. ESD indication is simple: intermucosal and SM slight cancer, for which en-bloc EMR is difficult to apply. In this diagnosis, magnified NBI, JNET, and PIT pattern are essential. Let's move on to the main results. Curative resection was achieved in 91% overall, including 79% complete curative resection and 12% of incomplete curative resection, which result in lateral tumor margin, positive or unknown. Histological findings were 40% adenomas, 39% intramucosal cancer, 7% SM1, and 8% SM2. These are short-term outcomes published in Digestive Endoscopy from CREATE-J. As shown, right colon also showed 13.6% SM invasion and 5.6% deep submucosal invasion. Combining the growth type and morphology, we found SM invasion in 17.5% of LSTNG and 27.4% of non-LST in the right side colon as well. Completion of ESD was achieved in 99%. Finally, even by an expert, 1% ESD procedures were discontinued due to the technical difficulty. Among them, 90% were finally diagnosed as curative resections. 99.5% of curative resections were followed up with the protocol. 31% dropped from surveillance. Ultimately resulted in 0 deaths from the primary disease and 5.8% deaths from other disease. Finally, 94% were survived from follow-up cases. Only 0.4% patients underwent surgery due to the delayed perforation. All 7 surgical cases also survived except for 2 dropped cases. On the other hand, 153% patients, 8.9% of all completion of the CESD had non-curative resections. Among them, 72% were operated on according to the JSCCR guidelines, and 43 cases, 28% were followed up due to some reasons. 3 of the surgical cases for non-curative resection, 3% died of the colorectal cancer, and 6% died from other disease. Finally, 91% were survived. In follow-up cases, 1 patient, 4% died of the underlying disease, and 16% from other disease. So finally, 80% were survived. This is one of the key slides. Kaplan-Meier curve revealed that disease-specific survival rate was significantly higher in patients with curative resections than in the patient with non-curative resections, demonstrating the validity of JSCCR guidelines. The 5-year intestinal preservation rate was 88.6%, which was substantially high in patients with curative resections. And the same tendency was also confirmed in overall survival rate. During the median follow-up period, mean number of 2 times of surveillance colonoscopy was performed per patient. The local recurrence has occurred only 0.5%, but all the local recurrence was successfully resected by repeat endoscopic resection. A total of 1% invasive cancer was detected during the surveillance. Let me now turn to discussion. The major strengths of this study were largest number of enrolled patients, 5-year long follow-up duration, and high follow-up rate and prospective design. Important clinical implications were we demonstrated that JSCCR criteria is effective as no metastatic recurrence was detected in patients with a curative resection. High proportion of the patients who received additional surgery may have prevented metastasis recurrence and led to a favorable prognosis. Limitations is This is not a randomized control trial. However, an RCT of ESD and EMR is currently ongoing in France, and we look forward to the results. In this multicenter cohort study, favor long-term outcomes after colorectal ESD. The 5-year DSS and OS were 99.6% and 93.5% respectively. To note, the 5-year intestinal preservation rate was 98% when curative resection was achieved. ESD can be a potential first-line therapy for superficial colorectal tumors. Finally, indication for ESD including intermucosal cancer, as it is difficult to extract only SM1 cancer. Even with preoperative JNET diagnosis and PIT pattern diagnosis, 40% of adenomas and 8% T1B cancer included. Also, local recurrences as low as 0.5% when en bloc resection by ESD, extending the surveillance interval is possible. Patients with ESD eligible lesions are more likely to have metachronous cancer of 1%. Surgery is required when the JSCCR guidelines indicate non-curative resection, and this indication could be appropriately extracted with en bloc ESD. Thank you very much.
Here are my competing interests. And the paper we will discuss about is the long-term outcomes after endoscopic submucosal dissection from a prospective multi-centered cohort trial in Japan. So first, this is an impressive study with about 2,000 patients from Japan. Some of them were excluded from the beginning for registration or error and cancellations for the fact that it was not epithelial lesion finally when they received the patient who were addressed for ESD. Only 20 failures of ESD, which is quite impressive because the rate of failure, of technical failure is very low. And we will see that 117 patients underwent surgery because the resection by ESD was not curative. And we have the results about the long-term follow-up of these patients who underwent the surgery or who were followed up because the resection was non-curative. At the final, 1,600 patients were eligible for the primary objective with only 166 patients lost of the follow-up during the long-term study. So the results are very good with an en bloc resection rate of 97%, curative in 90%, which reveal that even for the master of characterization and probably the country where the training in endoscopic characterization is the best organized, you still have around 10% of the cases that are non-curative. That means that some of the cases are done to get the specimen, analyze it by pathologist, but finally, the patient is not cured by the ESD because the cancer is more advanced than probably focused on the endoscopic analysis. And this is the histology that will correct the diagnosis and make the patient enter in the surgery process or an additional treatment to be completely cured. And this is important. This underlines that despite the fact you think there is an indication for an endoscopic resection, there is still 10% of cancers that should have an additional treatment. And if you have chosen EMR for this lesion, you could have a non-R0 resection and potentially a loss of information about the lesion itself. And finally, the R0 curative rate, so the resection that were curatively treated with margins laterally and deeply, is around 79%. Next thing, when ESD is curative, it is very effective to cure the patient definitively because the disease-free survival was 100%, with organ preservation in 98% of the cases, and a very low risk of delayed local recurrence between 0.2 and 0.5%. Therefore, there is an interest to have a long-term follow-up for this patient because we have seen in the paper that many of them will have metachronous lesions later. But could we clearly skip the early follow-up at 6 months, for example, and possibly the 1-year follow-up for this patient who have had an R0 curative endoscopic submucosal dissection, because we know that they will not have a recurrence in the first year after the resection. So probably it could be a way to reduce for the patient the new colonoscopies, which are a source of stress, of quality of life impact, but also to reduce the economical and the ecological burden of repeating colonoscopies. And comparatively with piecemeal EMR, where the recurrence is low now with the new techniques, but still remains around 5 to 10%, this early follow-up cannot be skipped because the recurrence will be seen at this time. In your study, there is a rate of 15% of T1 cancer, 8% for T1A, 7% for lesion over T1A, I mean more than 1,000 microns of invasion in the submucosa. In most of the EPMR, piecemeal EMR studies, the rate of T1 cancer is around 7%. I would like to discuss with Dr. Saito, but we will do also with Peter and Helmut after my presentation. How can we clearly explain a so large difference of T1 cancer between EPMR and ESD? Is it only a lesion selection? But we see in this study that almost all lesions of more than 20 millimeter in the JGS guidelines are sent for ESD instead of EPMR. Is it but because we can have differences in the rate of cancer between Japanese and Australian patients? But I don't think so. Or could we imagine that there is a loss of information induced by the piecemeal EMR? And this is something Dr. Saito is defending for a long while now, but I really think like him that when we propose a piecemeal specimen to the pathologist, it is more difficult for them to clearly underline the cancer, to see clearly where is it in depth, and is there any high-risk factor like budding, lymphovascular invasion, etc. So for me, this difference is possibly due to the damage introduced by the piecemeal EMR. And it is for me very important to see that when we have a perfect analysis, thanks to ESD, we can clearly make the patient safe, because he will be followed up for metachronous lesion if there is no risk, or if he will have a surgery or a follow-up, thanks to this very clear and precise analysis of the specimen. So thanks to your result, we see that ESD is for the moment the most efficient technique to cure completely a patient, because EPMR has a low rate, but not perfectly null, because even with thermal ablation, it is a 3 to 12% of local recurrences. So it was a provocative question, but we will discuss after. Is there still a place for EPMR to treat colorectal neoplasia when ESD is available in a center, or when ESD can be obtained by a patient without crossing all the country to get a center that is able to do it? I was not convinced before coming to Japan, but after 1 year seeing only ESD, now I have really the same idea that we should probably, as soon as it is possible, do an ESD to have a perfect analysis and to get a very low rate of recurrence, a quite null recurrence rate when the resection is R0 and curative. But probably there will be a discussion after this presentation. And finally, the last point, the results are very good in Japan, but the training in ESD is organized since 20 years now, because the first cases were in 2001. The skills of the endoscopists are probably better than the common skills we have in Europe, because ESD was not really a weapon until now. And I had a question about how to reproduce Japanese results. Is there a place now for traction-assisted ESD? And one of my questions was, is there any traction-assisted strategies in this study? Because it was not really clear in the methods. The strategy was left to the physician, but we don't know exactly what part of traction-assisted ESD was done in this study, and what is the place of traction-assisted ESD now in Japan to make people have a reduced learning curve and join the results of the experts more quickly. In conclusion, I think this paper is very important because it demonstrates in the long term the safety when you get a perfect ESD, which is curative. My question is, can we really reproduce these results in Europe now, thanks to the new technical points? We know that when it is curative, ESD is very safe in the long term to avoid local and distant recurrences. And I think that we should probably change the guidelines to clearly propose to skip the early follow-up when the resection is curative and R0. And we also see in this study that when we were not curative, thanks to ESD, some patients were followed up and some underwent surgery, and the disease-free survival was similar in the two groups. That means now we should know more about the differences between the patient who benefited from surgery from the one who had a follow-up, and to see which criteria should become something we can follow up and which one is still a clear indication for delayed surgery to avoid recurrences, for example, in the lymph node. It was a pleasure. Thanks a lot to Dr. Saito for all the things I learned with him in Japan, and I hope the discussion will be very interesting. Best.
Well, thank you very much for these excellent presentations, both Dr. Saito and also Dr. Pioche. Helmut, we see that you are online, but we cannot see your face. Do you have any comments from your side? Okay, then I think we move on. I think some interesting issues were raised by Mathieu regarding your presentation, Dr. Saito. Would you like to comment on that?
For whom your question? Yeah, I'm really happy with the this meeting, and Mathieu Pioche commented the several very important points to the comparison between EMR and ESD. And as Mathieu pointed out, so the difference of the submucosal invasion between the piecemeal EMR case series and the Ambrock ESD case series, I also believe that the difference should be based on the histopathological diagnosis. In Japan, 20 years ago, we are also doing the many piecemeal EMR for the large LST specialties. The incidence is very low, maybe 1% or less, but we experienced several cases of invasive cancer recurrences after piecemeal EMR, even that is high-grade dysplasia in the West. And then, so we also stopped to perform the multiple piecemeal EMR for the large LST lesions recently. That's it.
Mathieu?
Thank you very much, Dr. Saito, for your presentation and for these comments. I have the same idea. In the randomized trial you talked about, Dr. Saito, the difference between T1 cancer in the two groups is 6-fold more T1 cancer in the ESD group than in the piecemeal AMR ones. Despite the fact that the effective are low compared to your study and that the significant was not reached with this number, our hypothesis is also that it is more difficult for pathologists to detect all the submucosal invasion points in a lesion when you provide several pieces. And what we did during this randomized trial is to count the number of pieces we have cut with the snare compared to the number we have to send to the pathologist. And we had only 50% of cases with the same number in the two groups. I mean, in a lot of cases, we had less numbers of pieces sent to the pathologist compared to what we cut. And in 35%, we had more pieces because some pieces were cut in several pieces once they get in the box. So I think that it is more difficult for pathologists to have a precise assessment with a piecemeal resection.
So we have two questions. One question came from you, Mathieu, that was about the technique of ESD that was being used. Were there differences between the centers in the ESD technique used?
In
Dr.
Japan,
Saito?
you mean?
No, the question is for Dr. Saito. You asked to Dr. Saito whether there were differences in the technique, in the ESD technique between the different centers. Can you comment on that, Dr. Saito?
Oh, thank you very much. So recently, there are various techniques to improve the ESD difficulty. The one is the pocket creation method, and the second is a tunneling method, and the third is the traction assisted ESD. Actually, the concept is the same to make a good traction for the ESD, but of course, there are some difference of which strategy to use in the various endoscopy centers, even in Japan.
Okay, but could that have made a difference in the study results that different techniques were used, or do you think the results were not influenced by the fact that different techniques were used? And of course, this study was done already 4 years ago, so that's also something I think we should keep in mind.
Yeah. Regarding our CREATE-J study, all of the 20 centers are expert centers, referral centers. Even using the different ESD strategy, the study result is almost same. The R0 resection, the curative resection rate is similar.
So that suggests that everyone uses or more or less the same technique. There's also a question from the audience, and I think that's a very important one because we know that quite a few of the people that are participating in this webinar are young endoscopists. And this question is as follows: what is the best way for beginners to start ESD in the center? And it's important the speaker or the author asked because this center is also a CSC screening center. So how to start ESD in your center? And I would like to ask this question to you, Dr. Saito, and also to you, Mathieu, to have your answers.
Okay, so in Japan, usually the trainee doctors start the from the gastric ESD. It's relatively easy, and the incidence of perforation is relatively low compared to colon and the esophagus. And the step up is really important, and at least minimum number of the gastric ESD might be 50 or 100 cases. And in the Western countries, we know there are no many early gastric cancer. In such situation, I recommend to start from the lower rectal LST. In the lower rectum, the incidence of the perforation is very low, and also the scope access is much easier compared to the proximal colon. And also in the Western countries, such as the Matthew or Helmut, maybe first step, the start from the only one experienced endoscopist to starting the ESD, to gather all of the ESD cases to one person. And after the ESD technique is standardized, maybe you can increase the number of endoscopists in your center. That is my opinion.
Well, that's important information, of course. Bancho, you went to Japan to learn ESD.
Yeah, what is very important probably is to follow the curriculum from ESGE, where all the steps are described about how to be a good ESD physician. Many things are coming from the experience from Japan, so I think we should follow the curriculum. But the big difference you have underlined, Peter, is that at my time we should go to Japan to have a large number of cases in the center. It's not necessary now because many centers in Europe have a large case of numbers. So it is still very interesting to go to Japan, but it's not absolutely mandatory like it was in the past. So you should see a lot of procedure because many different cases and many different strategies are needed. And you should have a supervisor, a mentor to help you in the first case in human, I think.
Okay, well, thank you very much. It's I think time to move to the next paper. There's still one question left in the Q&A app. I would like to ask you guys to answer this question to the person who raised this issue. So having said that, I would like to go to the next paper, a very interesting paper. This paper is entitled Motorized Spiral Enteroscopy, Results of an International Multicenter Prospective, etc. study in patients with a normal and altered gastrointestinal anatomy. A very important paper was published will be published in Endoscopy, and the paper will be presented by Torsten Beina on behalf of the whole group of authors that you see here on your screen. After this presentation by Torsten, there will be a commentary made by Marco Pennacchio from Italy, and he will discuss this study and put it in perspective. So I'm very much looking forward to both your presentations.
Good evening, ladies and gentlemen, dear colleagues, dear Peter, dear Helmut, dear Marco. It's a great honor for me to present today on behalf of the Submucosal study group as ESGE Endoscopy Paper of the Month, publication and the results of our multi-center prospective observational clinical study of motorized spiral enteroscopy results in patients with normal and altered gastrointestinal anatomy. So what do we know about motorized spiral enteroscopy? Till now we had two pilot publications. The first one showed that motorized spiral enteroscopy was effective and safe for patients for antegrade enteroscopy with a diagnostic yield of 74% and a low rate of complications. And the second trial, the TEMSET trial, published last year, could show that we could achieve a high rate of total enteroscopy of 70% in patients without previous surgery. So what were the key messages from the first studies? We had a very high rate of complete enteroscopies compared to double balloon enteroscopy. If we compare this with the largest meta-analysis about double balloon enteroscopy with more than 12,000 patients, 70% from the TEMSET trial to 44% from the meta-analysis, we can find that we have a very high rate of total antegrade enteroscopies. That was tenfold higher with 16.7% versus the 1.6% for double balloon from the meta-analysis. Power spiral seems to be superior compared to manual spiral enteroscopy in terms of retrograde enteroscopy because it provided a 100% technical success rate in our studies, and in terms of safety we had a low rate of major complications. Most of the mild adverse events were clinically asymptomatic. However, we had outstanding questions, mainly about safety and performance and learning curve of motorized spiral enteroscopy in real-life setting outside of motorized spiral enteroscopy expert centers, and also of motorized spiral endoscopy in patients after major abdominal surgery and with altered gastrointestinal anatomy. We can have a short look on the joint ESGE UEG guideline about deep endoscopy in terms of quality improvement, and we can see here that we have thresholds for complication rate, including overall complications, including perforation, bleeding, and especially pancreatitis, that should be below 1% for pure diagnostic procedures and below 5% for therapeutic procedures in an unselected publication. So then we conducted our trial, motorized spiral endoscopy, prospective multicenter study, the Submucosal trial, and our aim was now to evaluate motorized spiral endoscopy in a real-life scenario, including patients with normal and altered anatomy. So we included 10 European reference centers with huge experience in deep endoscopy, however variable experience in motorized spiral endoscopy, as we had expert centers from the previous trials and new starters in the new method of motorized spiral endoscopy. We had as a primary endpoint safety, namely the rate of serious adverse events. So we subdivided our trial into a training phase with 5 cases per investigator, only for starters with less than 20 cases prior to the study. And then we had a core study phase. According to the case number calculation, we should include a minimum of 245 patients. And after the enrollment phase had reached the halfway point, inclusion of post-surgical and altered anatomy patients was allowed as per protocol. So first, the new centers had to go through a basic ex vivo supervised training program with hands-on model training prior to starting with motorized spiral endoscopy in patients. And then we included the following patients. So in total, 298 patients that had an ASA score of 3 or more in almost half of the patients. 337 procedures were included, 241 from antegrade, 75 from retrograde, and only 21 combined single session procedures. 89% had positive findings in previous imaging modalities. 21% of the patients finally had previous abdominal major surgery, and 10% surgically altered anatomy. These were the results in terms of the primary endpoint. You can see overall rate of major complications 2.3%, and if we focus only on the core study phase, this was 2.0%. So good results, and as you can see, the respective upper limit of the 95% confidence interval was also below the 5% threshold that we know from the guideline. As you can see, the training phase had 2 major complications, 4.3%. However, the results are limited by the fact that we have only a small number of cases in this group, and therefore the 95% confidence interval is very high. So in detail, we had 1 perforation, 2 bleedings, 1 deep mucosal laceration, 1 unintended premature disassembly of the spiral overtube that could be solved because it was in the esophagus, but remarkably no pancreatitis occurred in the study. So we had a closer look onto some subgroups in terms of safety and the major complication rates. Especially the diagnostic group, 0.79%, below the 1% threshold from the guideline, and interventional procedures 3.49%, also below the 5% threshold. However, the study was not powered for this subgroup analysis, what means that these findings were not statistically significant. Remarkably, all but 1 major complication occurred during an antegrade procedure. And to have a closer look onto patients with previous abdominal surgery, you can see it here. Previous surgery, 1 event, 1.9%, and this 1 event occurred in a patient with altered anatomy. It was then 1 event, 4%. However, there was no further discrimination because we had only one event in this group. Remarkably, no increase in complication rate when the patients were still on aspirin. One event occurred in the patients with Crohn's disease, and remarkably, no difference, no statistically significant difference between the use of deep sedation or general anesthesia in our study. Procedural success rate, also quite impressive. Procedural success rate, here the definition is to reach the target region of interest, was 88%. Remarkably, in more than 50% of the cases that were planned for total enteroscopy, a total enteroscopy was achieved. Diagnostic yield 83%, therapeutic yield 60%. Learning curve analysis showed the following. As you can see, the rate of major complication decreased despite the fact that we had increase in complexity of the patients. No significant differences in terms of diagnostic yield, therapeutic yield, and procedural success rate with respect to the different study phases. Comparing the centers with different level of experience, we can see only one major complication occurred in the expert group, and all the other serious events occurred in the new starter groups. So our study has also limitations. The study was powered for the overall rate of serious adverse events, and subgroup analysis were limited by the small number of subjects in the respective groups. We had no direct control group, and we had also a heterogeneous composition of the study centers with different levels of experience. However, we feel that involvement of the centers with two different levels of MSE experience and different study phases that were related to the complexity of the patients reflects real-life clinical praxis and also addresses the learning curve as an internal control group very well. So the key messages were that we have first international prospective multicenter study of motorized spiral enteroscopy. It was feasible and safe in a large cohort of patients in a real-life setting at centers with experience in deep enteroscopy. After a short learning curve, it was shown to be feasible in post-surgical patients, including those with altered anatomy, without an increase in the rate of adverse events. And the sequel study, Submucosal B, on power spiral-assisted ERCP is currently recruiting, and the results are expected spring next year. Thank you very much for your kind attention.
Good morning. I'm Marco Pennazio from the University Division of Gastroenterology in Turin, Italy. Thank you for inviting me to comment this study proposed by Dr. Bena and co-workers concerning motorized spiral enteroscopy, the results of the international multi-center prospective clinical study. These are my disclosures. First of all, I would like to draw your attention about the strengths and the significant contribution of this study. This was an enlarged international multi-center observational study with prospective collection of data. This is very important. And very important, the safety analysis was chosen as the primary endpoint. It is important to do such a study because when a new technology enters clinical practice, we have also to know not only the technological performance, but also the safety of this procedure. Also, a step-up approach was taken to analyze the learning curve of this procedure. And very importantly, this is the second study that included patients with previous abdominal surgery and with altered GI anatomy. The key findings of this study have been already reported by the main author of this study. Briefly, the overall severe adverse events were 2.3%, which is not too bad. This was slightly higher in the training group, 4.3, but not increased in the post-surgical patients. It remains 1.9%. Also, the severe adverse events rates for diagnostic and therapeutic procedure were 0.79 and 3.49, respectively. This is very good results of this study. We have to underline that this study has some limitations, but not very important limitations. First of all, the severe adverse events rates were below the thresholds of 1% and 5% for diagnostic and therapeutic procedures as proposed by the ESGE guideline. But this study was not adequately powered for this subgroup analysis. And this, I must say, was clearly highlighted by the authors of this study in their discussion. This was a study conducted by experts with different level of expertise, but expert in enteroscopy, and was conducted in tertiary referral centers. I don't know if we can already generalize the results, but it might be underlined that this was a study performed in expert centers. More importantly, 40% of the procedures, the motorized parenteroscopy procedure, were performed at 2 centers with a vast experience with motorized parenteroscopy. If you look at the summary of the studies evaluating motorized parenteroscopy reported so far, we are less than 800 patients reported so far. If you look at the result of this study we are talking about, the results are in line, at least in terms of diagnostic yield and therapeutic yields, concerning comparing with the study already published. But more importantly, the total enteroscopy rate remained high, and if you look in line with the results of previously published papers, and if you look at this study proposed once again by the group of Düsseldorf and Brussels, the total enteroscopy rate in this study was 70%, and this study was clearly on patient to assess the total enteroscopy rate with this device. If you look at the measured adverse events, 2.3 was the studies, other studies reported 0%, but anyway, probably some of the minor adverse events classified in this studies probably could have been also reported at the measured adverse events. Concerning minor adverse events, 8.7 this study, but we have to expect these events to happen in a quarter of patients. A few questions and some points to discuss with the experts and with the audience. What about the learning curve? I'm not so sure, but I don't know if how many procedures are considered enough to get command of this procedures. I don't know if 5 procedures, 10 procedures for the oral approach are enough. But if you look at the device-assisted enteroscopy, it has been reported that at least 20 to 25 procedures for the oral approach and 30 to 35 procedures for the anal approach are necessary to get command of this, to become very expert with the device-assisted enteroscopy. What about safety? Can the promising data currently available be generalized? With data about 800 patients, if you look at the data available for double enteroscopy, explorer enteroscopy, we have data on more than 10,000 patients. Probably also in this new field, it could be useful to have some database registries of complications of motorized parenteroscopy in order to know how the procedure performs outside a clinical study. There are also some peculiar drawbacks of motorized parenteroscopy. The premature disassembly of the spiral over tube has been reported in 3 cases so far. I don't know if this is related to the technique, the device. Maybe we have to discuss with the experts in order to avoid this to happen and just to have an explanation of this. And also how to avoid, if possible, the so-called spiral-related injuries related to the spiral itself and the possible spiral infection issues as caused by in the post-surgical patient, which is the most difficult to manage. And also just to conclude, what is the ideal sedation regimen for oral enteroscopy with the motorized parenteroscope, the more cumbersome procedure? Because if you look at the literature, most of the studies, most of the patients underwent general anesthesia with endotracheal intubation. Also in the study, 95% of the patients underwent this form of anesthesia sedation. If you look at the previous paper reported by the Dutch group, Altoma and Cohort, they use only sedation with propofol. So we have to discuss if there is, although the sedation regimen, the sedation policy depends on many local organization protocols, we have to discuss if it's always necessary general anesthesia. And one philosophical question is motorized parenteroscopy for every patient or just for some? What is the target population of this technology? Because if you have already in your department parenteroscopy, double enteroscopy, you have to avoid to use them in the future and use always motorized parenteroscopy, or there is a particular situation in which one is better than the other. And so we have also to underline that head-to-head comparison with double enteroscopy is still lacking. I finish. I would like to thank again Torsten Benja and co-workers for the elegant studies, and thanks once again ESGE for giving me the opportunity to discuss and comment this paper. Thank you.
Thank you, Torsten, for an excellent presentation. I think an important study that shows a new technology and also some of the perspectives that are needed for the future. And I think I also like to thank Marco for his balanced commentary, and he actually also raised some important issues, I think, that deserve some discussion. Torsten, would you like to comment as a first feedback?
Yeah, so first of all, I would like to thank you because you have heard that the paper has been published in Endoscopy, and so it's always a little bit difficult to discuss some points we have a new technology, so that was very good that we finally managed. And of course, I thank Marco for this excellent critical comment on all the points that some of them we also discussed in our trial. And last but not least, thank Mathieu Pioche also for participating as a study center in the trial. So it's very good that we can discuss together. So some points that you have already mentioned were, of course, about the training. That's sure. So we have to keep that in mind, so that we had, as you mentioned, centers that were experienced in deep enteroscopy and in interventional endoscopy in general. So maybe for this group of centers, 5 cases seem to be enough to get used to the technology. I think currently the manufacturer Olympus is doing a good job because they provide a certain certification workshop that you have to go through and to learn some critical parts of the antegrade procedure that are necessary. When you pass the upper esophageal sphincter, you pass the pylorus ligament triads, these are important steps. And from my perspective, I think it's not only the number of cases, but the sequence of cases. And this is what we try to reflect in our study, that we start with less complex patients, not patients without previous surgery, patients in whom we don't expect difficult access, and then do the step-up approach. So I realize in a lot of discussion that the first question that I get from the audience is, does this work in ESCP? So this is, I think this will work, but this is not the right approach from my perspective. And in terms of specific complication, I think this was also a question that you addressed to me, was
yes.
This training purpose also applies to the fact of this unintended disassembly of the spiral. There was point 1, a very nice publication also in endoscopy that showed that this occurred to one group once, and they could solve the problem and remove the spiral from the small intestine. I think this was a video case that has been published. But second, what's very important is that there's a real focus of the entire team on this, on the procedure that is needed to get the spiral enteroscope started, to connect the overtube to the rotation coupler. This is a very critical procedure, and this is a double locking safety mechanism, and you should not touch this when you insert the spiral into the patient, and you should use a dedicated mouthpiece. So we discussed this in the discussion part as well, that this in this specific patient, not the dedicated mouthpiece that comes together with the overtube was not used, and they used a different smaller mouthpiece, and this may have led to this because it's a little bit bulky, the system, and maybe this mouthpiece has touched the connector of the rotation coupler, maybe.
Okay, I have a question for you, Torsten, if I can. What about the sedation regimen? Because you know, this is a very fast procedure compared to the double balloon enteroscopy, but it can become very long because of anesthesiological problems. So because if you if you say that general anesthesia is required, it could be a problem for centers that have to schedule several procedures one after the other. So we have to decide, because the Dutch group in the previous issue of endoscopy showed that the general anesthesia is not necessary. You are the experts. They say that sedation with propofol is enough. Is correct? Sedation with propofol is enough or not? We have to be clear, because we have also to discuss with our anesthesiologists that they are sometimes afraid of this big tube, but we have also to explain that it's not so difficult to perform this procedure. What is your opinion?
Yeah, very good and important question, of course. So as you mentioned, the first pilot trials that we conducted were done using general anesthesia, but this was mandatory as per protocol, because we had to do this also because we had a very new technology. Also, the first in human case of the technology was included in the first trial. So we wanted to be very on the safe side, of course. So, but in the meantime, we realized this works very well without intubation, and we use propofol and midazolam. But this is still an individual decision. So currently we do, I think, 95% of our procedures without general anesthesia, even in the patients that are not that have ASA3 status, for example. If we use general anesthesia, it's only the 5% that could include if we expect unsafe airway, for example, or if we have very severe cardiac or circulatory or respiratory comorbidities, for example. But this is all always an individual decision. We do most of the cases without. And our strategy is, and this is a very good point that you made, that you should discuss with your anesthesiologist how you can manage this. So our strategy is, even if the patient would need an emergency intubation, what, by the way, I think we did more than 500 procedures in our department to now, never happened. There was our strategy is that we leave the scope in the patient, could do intubation alongside the scope, and then we have all the time we need after stabilization of the patient to extract the scope. But this is an individual decision. This may also differ from country to country, as we are lucky that we can give propofol on our own. And for example, our colleagues from Belgium, they are more or less used that every patient is intubated. Yeah.
Okay. So just one final question. Thank you very much for your answer. That's an important, I think, issue to mention here. One final issue is spiral enteroscopy going to replace double or single balloon enteroscopy, or is there still a place for balloon enteroscopy?
Short question. Currently, it cannot totally replace balloon enteroscopy, I think, because there are some contraindications. For example, severe strictures of the esophagus, eosinophilic esophagitis. I would not recommend to do antegrade spiral in this group of patients. And currently, we are still a little bit The patients that, for example, Crohn's patients with a couple of strictures, one after the other in the small bowel. We all know these very nice videos, for example, from Professor Yamamoto's group that they dilate 14, 15, 20 strictures one after the other, and I would be a little bit scared to pass these strictures after dilation with a spiral. So we did this, but not in maybe 10 strictures one after the other. So we need definitely data on this. Currently, we also have the double balloon in our unit, and we use it in some cases, yes.
And what about the performing ERCP in complicated anatomy? Is that well? Of course, you are still studying this, but do you expect that it will completely be replaced by spiral endoscopy, or is it maybe too early to say so?
It's a little bit early. I'm very confident that most of the cases can be done with motorized spiral because it's very quick. You have a very stable position there, and it's a short endoscope, 3.2 millimeter working channel. We can use standard instruments, so it's very convenient to perform this. But one major difference compared to the long overtube techniques is that you cannot maneuver the scope independent from the spiral. So in some patients where the hepatobiliary loop, for example, or the way to the excluded duodenum is very much fixed, that you cannot pass it with a spiral. So we have around 5% of the cases now that we cannot do. I think there's room for a technique that uses a long overtube, and then you can pass to or move on to the papilla or the anastomosis by just pushing the enteroscope and leave the overtube in place. This you cannot do with motorized spiral, but we are very happy that we are currently conducting this prospective multicenter trial, the Zamisen-B trial, and hopefully we can publish our own data on motorized spiral ESCP, the ones that we have till now, as soon as possible.
Well, thank you very much. I'd like to thank you for your contribution to this webinar. Again, an exciting webinar, I think, and I think this is the end of the session now, because it's over after 8 o'clock, and we do not have any more questions in the Q&A box. Thank you again.
Thank you.
Thank you to all of you.
Thank you. So we have a couple of slides that we finish with. First, of course, that there will be very soon next year the next ESGE days in Dublin, in Ireland. Please note this date in your calendar, because we expect and hope you can be there. At the same time, of course, it's important to realize that it is fantastic to be a member of ESGE. It includes many advantages: eligibility for fellowships, research grants, reduced registration fees for ESGE days, but also free prescription to endoscopy journal, etc., etc. So there are many profits for being a member. And realize that if you are joining us, that it is no longer, at least now it is no longer 195 euro, but you can sign already in for 150 euro. And of course, you should ask your national society about dual membership. And then the final slide, very important. In 2 weeks' time, there will be the next webinar. It's a live endoscopy webinar, reinterpreting colonoscopy in the era of artificial intelligence, with an excellent faculty, as you can see. And I hope that you can join also in 2 weeks' time. And finally, this is only possible, this webinar, by the input from many, but I think it's important also to mention here David Imker, and also Gabriela Varga. Thank you very much all, and I wish you all a very pleasant evening.